Alrighty, so this is going to be part 3 of the mental health lecture. This part is going to be going over schizophrenia and schizophrenia-like disorders. Okay. So schizophrenia is described as being a disorder that is based on disordered and bizarre thoughts, perceptions, emotions, movements, and behaviors. It's not defined as a single illness, but is rather a syndrome or as a disease process with many different varieties and symptoms. So this is the thing. So the patient can be psychotic. So psychosis refers to a range of conditions that affect the mind where there's no contact with reality, disorganization of personality, and deterioration of social functioning. So the nurse says the client is out of touch with reality and has disorganized thoughts and behaviors. So they're going to have those very different types of behaviors. So here's the criteria of schizophrenia. Remember, it's very important that we follow these criteria because it can be very deteriorating if we place a label on somebody, because once that label's there, it's going to stay with them forever. So 2 or more of the following, and 1 must be of the first 3. So they're going to have delusions, hallucinations, disorganized speech, grossly disorganized or catatonia, and then the negative symptoms. So we're going to go over that. But what I wanted to touch on first is that development. So schizophrenia is more likely to be onsetted in adolescence, so between ages 15 and 35, but in males it's going to be a lot earlier than females. So the first stage is going to be that premorbid phase. So the patient might become shy and withdrawn, poor peer relationships. They might be a like A+ student in like the 6th grade, but when they get in high school, they may start failing their classes. But they're going to occur prior to clear evidence of an illness. So we're not going to think that there's something going on. We might think that there might be added stress or something that's very acute rather than something that's catastrophic like schizophrenia. They may be passive, introverted, not like themselves. So prodromal phase is that period between premorbid and that first onset of psychosis. It can last 2 to 5 years. They may still have that deterioration in functioning. They're going to have cognitive impairment. They may have different types of behaviors that occur. And then stage 3 is when they're going to have that first psychosis occur. So they might have they might have an hallucination or delusion. They might be hearing or seeing something that's not there. They might have a command to do something that's not very good often. And then residual is when the symptoms of the active phase are no longer present. They're going to be very flat, or they're going to have functioning impairments. Let me hop back to the doc. Now, they mentioned that they wanted to go over the positive, negative symptoms. So we're going to hold off on that. Let me go over, see if we have anything based on risk factors. Other interventions. Sorry, I did not make this part of the doc, but I'm going to try and follow it the best I can. So risk factors, of course, age. Remember, it occurs in younger adolescents. Family history, genetics. If somebody in your family has schizophrenia, they're more likely to have it. Down syndrome, there's, I guess, correlation between Down syndrome and having schizophrenia. Cognitive impairments, for example, maybe they have autism. Maybe they might start having signs of psychosis. Head trauma. If your brain is messed up, then it can cause that neurotransmitter imbalance to occur. Air pollution, alcohol consumption, because alcohol consumption can cause hallucinations and delusions. Poor sleep patterns, and then lifestyle and heart health. There's different biological factors. Remember, genetic evidence, there's multiple genes that create the possibility. There's the brain structure abnormalities. There's ventricles are enlarged, not enough gray matter, low hippocampus, reduced symmetry abnormalities, white matter abnormalities. So we have the dopamine theory here too. which basically means that there's excess dopamine in the limbic system and decreased dopamine in the prefrontal cortex. And there's an increase in neural activity, increased production of dopamine or too many dopamine receptors that can cause schizophrenia to develop. And then there's going to be abnormalities in serotonin, epinephrine, and norepinephrine. It can also be brought on by stress. Social and physical stressors can contribute to the severity and course of the disorder, often based on maybe leaving home, maybe new job, new work environment, new college. Okay. Now we're going to go over those, the positive and negative symptoms. So positive symptoms are things that add to the disorder of schizophrenia. So, for example, if you have your patient may report that they hear a voice telling them, maybe they're in a hospital room and they hear a cat purring. So that would be something that's very positive because they're adding stimulation to that. Same with delusion. They might have a grandiose delusion that they're the king of England. That's a positive symptom because it adds to the disorder. Plus, it's very positive because we're often going to see it. Well, now let's go over the negative symptoms are going to be things that are detracted or not always seen. Often, they're going to detract from one's life. For example, anhedonia. They're going to have no joy or pleasure in life. So that's something we may not be able to see. And one thing we have to teach the family about negative symptoms is that we need to teach them how to recognize when the patient's going through that, because oftentimes we're not going to see the negative symptoms. And we need to be able to treat those effectively because those are going to be the ones that are going to be worse. So positive symptoms are going to be ambivalence. They're going to have contradictory beliefs about events, persons, or situations. Loose associations, so they're going to have fragmented or poorly related thoughts and ideas. Delusions we went over, fixed false beliefs, no basis in reality. Echopraxia, they're going to have imitations of other people's movements or what a client observes. Flight of idea, they're going to be jumping around from verbalization, one topic rapidly to another. And then one thing I want to talk about is flight of ideas and then circumstantiality. So circumstantiality is when they start talking like blah, 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 blah. But that's going to stem from that flight of ideas. Hallucinations, those false sensory perceptions, ideas of reference, false impressions that external events have special meaning to the person. Maybe it's like 9/11, that they have a meeting that they were called to do 9/11. I don't know. But that's a thing. Preservation is adherence to a single idea topic, verbal repetition of a sentence, word, or phrase. They might say, you might be talking about flowers, but all they want to talk about is bed. They might be fixated on bed. And that's preservation. They're like, yeah, we're talking about flowers, and I used to grow a garden. Yeah, well, I grow a garden in my bed. You know, my bed has flower things. That's preservation. And they're not gonna be able to change that topic. Well, negative symptoms. Remember your A words: alogia, apraxia, anhedonia, apathy, asinogia. There's more on there. But alogia is speaking very little, poverty of speech. Absence of logical speech, alogia. Anhedonia, no joy or pleasure, apathy, feelings of indifference, blunted affect, restricted emotions. Catatonia is that immobility, they're kind of like in a trance. Flat affect, absence of facial expression, lack of violations, absence of will. Let me pull up some more here. Anhedonia, avolition, lack of motivation, asociality, lack of social interactions. Affective blunting, we already talked about. Alogia, we talked about already. Lack of logical speech. Affect's going to be very constricted. They're going to not be able to drink. So which ones would be the 7 A's? These ones. 1, 2, 3, 4, 5, 6, 7.
Okay, got it. I was confused. Like, the one from above that you were showing with the chart. That's what I thought was
I
part
didn't
of
make
this.
that chart.
Oh,
I didn't make that chart.
got
But
it.
this is what the book says. But yeah. And then affect, they're gonna also have problems with thinking. They're not gonna be able to drink abstractly. So, like, for example, you ask them to interpret something, they're not interpret like a statement. Like, you have to life gives you lemons, you have to make lemonade. They're not gonna when life gives you lemons, they're not gonna be able to interpret that sentence or what it means. They're gonna think that lemonade is good. When life gives you lemons, make lemonade. They can't interpret that. So that's something called concrete thinking. They're going to have impaired memory, not going to be able to process, not going to be able to function. Now let me go over some more. So we need to go over the types of delusions. So let me pull up my Quizlet. I like my Quizlet better than what the doc says. Because whoever made the doc didn't do it. Well, I'm not going to diss on them. But I like of course this isn't. Here we go. Types of delusions. So we're going to go over erotomatic. So erotomatic is when an individual believes falsely that another person's in love with him or her. So, like, for example, I think that, I don't know what a popular Justin Bieber is in love with me. Well, I don't even know, I've never met Justin Bieber in my life. But somebody with schizophrenia might think that Justin Bieber is in love with them. So that's an erotomatic delusion. Grandiose delusion. They have special power, unique knowledge, or is extremely important. Maybe they think that they're a Hollywood celebrity when they're not. That's grandiose delusion. Maybe they think that they're the president. That's a grandiose delusion. Jealous disorders or delusions is when individual sex partner is unfaithful, so they think that their husband's going to see another woman when they're not. Persecutory delusions are very important to know because they're false beliefs that one's being pursued by other people. For example, a patient might tell you that they're sought out by the FBI or sought out by the police when they're not. Somatic delusions is when they believe that their body's changing in an unusual way. Maybe they think that they have their arm is a snake. Maybe they believe that they're growing a third leg or a third eye. That's a somatic delusion. Reference delusion is that certain objects, events, or other people are significant to them. For example, maybe they think that the presidential inauguration is important to them. That's just an example, when it's really not. Control delusions is also very important to know because control and command delusions can cause a person to do serious harm to themselves or others. So control delusions is when another person or a group of people controls thoughts, feelings, or impulses or behaviors. So, for example, a patient might think that the FBI is out to get them and they're off to kill, that the FBI wants the patient to kill their psychologist, and that's a problem. So, that'd be like a control delusion or command delusion. Or command delusion might be that there's an external influence telling them to do something. So, hallucinations, on the other hand, or like hearing, seeing things that aren't really real. False perceptions. So, for example, auditory hallucinations are a very big thing here because a patient might hear a voice to go out and kill somebody, and we want to know that. So they can hear, but however, they can also hear different noises or sounds. For example, they might hear a cat purring or a dog barking in the room, and they might get scared if they have a fear of dogs. Visual hallucinations, they may see something that's there. Maybe they see a spider or like a tarantula on the wall or a snake in the room. Olfactory, they might smell something that's not there. Maybe they smell their grandmother's cookies. Well, they're in the hospital, they can't smell that. Gustatory, maybe they taste something that's not present. Maybe they're tasting chocolate chip cookies when they're not tasting them at all. Somatic hallucinations is that there's something happening in the body. Tactile is that they can feel something. Maybe they feel that their bed is full of nails and that they're sharp. So that's tactile hallucinations. Command hallucinations are when something tells somebody to take action. When there's some type of hallucination telling them to take action. And that's a problem. Because their concern is that the command hallucinations and delusions can tell that person harm themselves or others. Sorry. So when we have a patient that's presented with a hallucination or a delusion, we need to, 1, ask about that delusion. Ask them what's going on, what the perception is doing. We need to ask the person, are they telling that is the delusion going to harm you, or is it telling you to do something? We need to then tell the patient, I don't see anything. I don't hear anything. And we need to orient them back to reality. Because we need to make sure that they focus back on reality here. There's some other things that might be apparent, such as magical thinking. A lot of times you're going to see this with children, but they're going to think that there's a belief that thinking about some occurrence that they're going to make happen. So like, I don't know. They're going to predict the future. Neologism is when they make up new words or expressions that they only know. For example, this isn't a word, don't go off me. They think that dearth is the best dearth on the best dearth. On the best confuzzly. Bleh. That's an only neologism. Because they're making up a new word that only makes sense to themselves. Echolalia is when they have automatic repetition of what others say. So for example, I might be talking about, I see a makeup brand. Black-owned makeup brands. They might say, own makeup brands black. That's echolalia. Echopraxia is imitating others. So they're going to be mimicking what they're doing. Maybe they're cooking. They're cooking. They're going to be cooking. They're going to be stirring the pot if one stirred the pot. Circumstantiality, again, is talking with excessive detail. There's a connection but are irrelevant. Tangentiality is when they can't get to the point of reference or communication because there's too many topics at hand. They go off on tangents. Cognitive retardation is when they're slowed pace in thinking. Symbolic speech is that they have symbols and words to convey an idea. That blocking is that they interrupt a thought process before it's completed. Thought insertion is when they believe that somebody's placing thoughts in their head. Thought deletion is when they've taken out those thoughts that can cause aggression. Clang associations are those really kind of like bell, tell, del, nell, hell. That's clang associations. Word salad is when they have incoherent speech, a jumble of words and incoherent speech. So that might be like duck, bird. No, that's a bad example. Duck, TV, keyboard. Panda. Picture. Couch. Pillow. Very not like together. Verbiation is repetition of words or sentences inappropriate to context of conversation. We already talked about preservation, ambience, and loose associations. Illusions are those perceptions that misrepresent physical stimuli. Depersonalization is feeling that detachment from one's mental processes or body, so they don't really know their identification. Derealization is when they lose a sense of reality with like the external world. They feel like they're a fly on the wall. Catatonia is when they're immobile, kind of like a statue. Hypervigilance is that ongoing anxiety, constantly tense and alert for threats. Waxy flexibility is when they have that maintenance of posture or position over time. So maybe they have their arms out after they're done taking vitals. They're going to hold that position there if they have waxy flexibility. Motor retardation, slowing of movement again. Motor agitation is when they start having that excited behavior. Maybe they're running in place or doing something else like that. Negativism is doing the opposite of what others want. So maybe the staff asks the patient to clean up their tray. Well, instead, they're going to go and wreck the bathroom. Let me see if there's any. For your A words, I would also add in no aphasia, so inability to speak. Agnosia is inability to recognize familiar objects. Okay. Go back. So we can often diagnose schizophrenia by, you can look at the brain structure, but I haven't seen that lately. So one thing we want to do with nursing care is provide safety to the client. And we want to know about those delusions and hallucinations and if they're telling the patient to do anything. Always establish trust. Be calm. Orient to reality. Never confront a delusion or argue with it. Remember, maintain reality and then distract the client. For hallucinations, always use communications, have description of the hallucination, and engage the client in reality-based activities. Maybe they say like, oh yeah, I see a lion in my room. I'm scared. But you're going to tell them, is the lion going to do anything? Well, no, it's just sitting there. Well, we're going to say, I don't see a lion. Here, let's go play cards. This might keep your mind off of it. We're going to distract them. If they have socially inappropriate behaviors, we need to redirect them and set our limits with our patients. We need to be non-judgmental, be factual, and never give punishments. For example, this behavior is inappropriate. You need to go to your room. That's all you have to do. Don't make them feel punished for inappropriate behaviors. We're going to talk about, okay, so questions we need to ask for the patient. We need to make sure that we do a medical assessment, assess for any medical or physical causes of the disorder. We need to assess for substance use because substance use can cause hallucinations and delusions. We need to do a full MSE, assess for your hallucinations. Do you hear anything? Do you have a voice telling you to do something? Do you believe what you hear is real? Assess for delusions, firmly held. Does the client say that there's a danger? Assess for suicide, assess safety and health needs. Make sure that when you do an intervention, you care for their physical needs first. Remember your Maslow's hierarchy of needs when caring for clients with disorders like these. Assess if they're taking their meds. One major thing with clients with schizophrenia, they're going to believe that they don't have a disorder, that they don't have a real factual disorder. So, yeah, they're going to be given maybe clozapine or something like that to take, or Abilify. And they're not going to want to take that med. They're going to be like, I don't have a disorder. And they're not going to take the med. And you know what's going to happen? They're going to come back in the hospital because the voice tells them to do something. So one big thing we need to teach our patients with medications for schizophrenia and use of antipsychotics is the patient needs to use the medication. Because if they do not use the medication, they're going to start having those psychotic symptoms again. They're going to start hearing voices. They're going to start having delusions. They're going to hurt themselves. So we need to know if they're taking any medications or if they're supposed to be taking medications. Because a big issue with our schizophrenic patients is non-compliance. And we also need to get the family involved. Because the family is going to often be the one that's going to see these changes first. And we need to assist the family in helping them with medication compliance and adherence. And if they feel like it's not working, we need to get them on maybe a different medication. Alrighty, so so our medications that we use are first generation antipsychotics and second and third generation atypicals. So remember, with our first generation antipsychotics, we have our haloperidol and chlorpromazine. We may give haloperidol with benzodiazepine to control the aggression if there's aggression. Remember, side effects, the normal side effects are going to be EPS. So EPS, remember, extrapyramidal side effects, they're going to be common with our first generation antipsychotics. Remember, those are those reversible movement disorders by neuroleptic medications like antipsychotics. So they're going to have dystonia, which is going to be spasms in like the neck muscles, eye muscles in the back. They may have dysphagia, tongue protrusion, spasms. The client might be having pain for that. You can give Benadryl or benzotropine, but we're going to be giving benzotropine more than likely if they have these EPS, early EPS. Pseudoparkinsonism is a big concern too. Remember, they're going to have medication-induced Parkinson's disease. They're going to have that shuffle-like gait, mask-like face, drooling, cogwheel rigidity. So we're going to also want to make sure that we can get benzotropine for that. Akathisia is going to be that restless movement, pacing, inability to remain still. Again, that's an early sign. However, tardive dyskinesia is a late sign. So with tardive dyskinesia, if we have this late sign, it's going to often be irreversible. So we can't really do much of anything. What's up?
I can't hear anything you're saying, so I'm going to log out and log back in. If the room is locked, can you let me in?
I will. I will see it. I'm still going to talk. So tardive dyskinesia is an irreversible side effect. They're going to have abnormal involuntary lip smacking movements, tongue protrusion, chewing, blinking, grimacing, tongue movements, but it's going to be irreversible, admit. So those are going to come with first-generation antipsychotics. However, a non-normal side effect that can happen with first-generation antipsychotics is neuroleptic malignant syndrome. So this is life-threatening if it's not taken care of. So one thing that we need to do and notice is a key feature is going to be they're going to have a high fever and they're going to be sweating. They're going to have muscle rigidity as well. But what we're going to notice first is a high fever. So what we're going to do is hold the medication, assess your patient, give IV hydration, and call the doctor, because if this is not taken care of, the patient can die. And we don't want that. And remember, we need to educate the patient on what to expect while using this medication, what not to expect, and how long it's going to take to work. Because often these atypical antipsychotics, they might take a few minutes to work, a few days to work. So, now we move on to our second and third generation atypical antipsychotics. So these are going to be a lot of your hematological and endocrinal effects with second and third generations. So we have olanzapine, risperidone, clozapine. So we want to make sure that we report any weight gain, drooling, sensation, hyperglycemia. We need to make sure that we measure blood levels with second and third generation atypical antipsychotics. Because a common side effect is a granulocytosis, which meaning we're going to have low white blood cell count and low immunity with use of these medications. So we need to make sure we monitor for any sore throats, flu symptoms, or fevers, and always monitor that ANC. And if we do, we're gonna report that because we need to switch to that medication. Never give the patient with dementia because it's not gonna work. Olanzapine, similar things, but no antigranulocytosis. But it's less effective. No EPS with these drugs. A Preprazole is that third generation antipsychotic. It's going to be headache, dizziness, drowsiness, tiredness, low indication of EPS. It's that third generation effect. And let me see if there's anything else. No, we need to see nursing interventions. Oh, I see something I need to go over. So, schizophrenia is a disorder. However, it has a blanket of other disorders that can be a part of it. So, delusional disorders occur when there's delusions that have lasted 1 month or longer. There's grandiose, persecutory, all those types, but they're not severe enough to impair occupation or daily functioning. Brief psychotic disorder is that sudden onset of delusions or hallucinations of catatonic behavior that lasts 1 day to 1 month. And then you never see it again. Schizophreniform is same as schizophrenia, but it's going to last less than 6 months. And then schizoaffective. So schizophreniform is like it's forming, so less time. So schizophrenia is forming with schizophreniform. So schizoaffective is it's affecting your mood. That's kind of how I think it. Schizo and mood. So schizoaffective is when they meet the criteria for schizophrenia and major depressive, manic, or mixed episodic behavior. So they have maybe schizophrenia and depression or bipolar disorder. Let me make sure. We went over meds. Okay. Make sure we do an assessment. Make sure that we listen and see if they're hearing voices. I already went over that. Remember that we need to make sure that we guide the patient and have a plan that involves both the patient and the family. Safety and symptom control is key, as well as orientation to reality. If they're hallucinating, we need to make sure that we call them by name, speak simply, be loud enough, have eye contact, redirect, have trust and report. Remember reality. Understand that you're frightened, but there's no one to harm you. Here, let's go play some chess. Delusions, remember, you never want to prove a delusion. You always want to orient them based on reality and focus on activities. For example, they're having a delusion that they're feeling like they're the king of the world. Okay, well, let's go play basketball outside. Always have doubt when doing this. Associative looseness is disorganized thinking. Remember, we want to make sure that we do not pretend understanding when you don't. I'm guilty of this. Place of difficulty to understand on yourself. Remember, a lot of clarification can be here. Tell the client that you do understand and reinforce needs and thoughts. Be concise and clear. Always paraphrase. Always have safety here. Always orientate to reality. Assess for suicide. Assess for suicide. What else can you do? Have structure. And you can distract them as well. What else is there? Oh, I think that's it. Has anybody got any questions on that? Anybody got any questions on like the meds or anything? Hello? Anybody got any questions?
Was it the antipsychotic med that you said caused low white cell count?
Your second generation antipsychotics, which is going to be clozaril or clozapine and risperidone and olanzapine. But olanzapine is going to have that lower incidence of that. But you might see more of those endocrine effects.
The endocrine effects of the weight gain and stuff like that.
Weight gain, hyperglycemia. We went over this in pharmacology.
Yeah.